Hello, everyone. Welcome to the CTTC Education Series talk on acute graft versus host disease. My name is Kareem Jamani. I'm a clinical assistant professor at the University of Calgary and in the Alberta Blood and Marrow Transplant Program. We're going to split this talk into two sections. The first is what I call acute graft versus host disease 101A, and this is intended to be educational for patients as well as their caregivers. There's going to be a section 101B as well, and patients and caregivers are certainly welcome to continue into that presentation if they would like more details. The target of the 101B section will be healthcare teams, particularly residents, fellows, advanced care practitioners, any members of our allied health teams. So thank you for being here with us today. The objectives for 101A are to cover important aspects of acute graft versus host disease, starting right from the basics. What is it? How does it happen? How is it diagnosed? How often does it happen? How do we prevent it? How do we treat it? And what is the prognosis? And what can you do as a patient or a caregiver? So acute graft versus host disease really is a butting of heads. It's the donor immune system butting heads with the recipient. And now what we know is that the donor immune system is going to have an advantage because it really hasn't been weakened by the chemotherapy and the radiation or radiation leading into transplant. But more specifically, this is a disease that happens when the donor immune system is recognizing the recipient as foreign. And so what we have is a donor immune system that's attacking target organs in the recipient. And so as you might imagine, acute graft versus host disease happens after allogeneic stem cell transplant and not after autologous stem cell transplant. And so what we mean by allogeneic is when you're receiving stem cells from a donor in contrast to autologous when you are receiving your own stem cells. And so what organs does acute graft versus host disease affect? And these are the big three. So skin, and this would be the most commonly affected organ, the gastrointestinal tract, and the liver would be the least commonly affected. It's important to know that a patient can have one of these organs involved, but not the others. And this would really be seen most commonly with skin. So what does acute graft versus host disease look like on the skin? This tends to be a sunburn type of red rash. It can be itchy or painful, and it can involve skin on any area of the body, including the palms and the soles. We have some pictures here, and the appearance of graft versus host disease on the skin can vary, as you'll see over the next few pictures. Here we've got small, what we call red macules, which are little patches of red skin, and papules that are kind of centered around the hair follicles on the legs in this patient. Sometimes the rash is even more obvious. Here's some very red spots when the palm is involved. And with more severe involvement, you really get this sunburn look here with a very red, angry rash on the back. There are some areas of skin breakdown in here. And so this would be more extensive involvement of the skin with graft versus host disease. When we talk about the gastrointestinal tract, we mean there's two parts of the GI tract. So there's the upper GI tract and there's the lower GI tract. The upper GI tract we refer to as the esophagus and the stomach, and the lower GI tract is the small intestine and the colon. And so patients who develop graft versus host disease of the upper GI tract tend to develop nausea, vomiting, and a lack of appetite. These are really common symptoms of chemotherapy, side effects of chemotherapy for the transplant. So this tends to be when the nausea, vomiting, and lack of appetite really persist or come back again, especially in the day 30 or more range after the transplant, when we're really expecting the chemotherapy and plus or minus radiation side effects to be getting better. With the lower GI tract, patients tend to develop very obvious watery diarrhea and sometimes abdominal pain as well. With the liver involvement, often the skin or the GI tract will already be involved by acute graft versus host disease, so they will already be present. And then we see the liver function become abnormal. It's pretty rare for liver disease to happen on its own without any other evidence of acute graft versus host disease. The symptoms and signs that a patient or caregiver might notice would be jaundice, so a yellowish tinge to the skin or the eyes, dark urine, pale stools, and what we're looking out for in the blood work as your transplant team is abnormal liver tests on the lab work. And so these are really a routine part of our post-transplant blood work monitoring strategy. So graft versus host disease, as the name implies, acute graft versus host disease, it tends to happen fairly early after the transplant, even as early as 2 weeks after the transplant, as soon as that new donor immune system is taking hold in the recipient. But it can happen really out to even several months after the transplant. And that means that we're monitoring patients and seeing them very frequently early after the transplant, because this is something we don't want to miss. How is it diagnosed? The skin is often diagnosed based on the appearance of the rash. It tends to be a very typical rash, but sometimes there are other possible causes of rash. Sometimes we're starting new medications. Sometimes there's the possibility of infection. And in these cases, a skin biopsy might be considered to confirm the diagnosis. With the GI tract and liver, a biopsy is really required, and that's because there are many other causes of diarrhea and liver inflammation after the transplant. For example, patients are on a number of medications and antibiotics that may lead to abnormalities of the GI tract and liver. So it's important for us to really confirm what we're dealing with. And infection is another consideration here. So we can't jump the gun without having a firm diagnosis, especially in the GI tract and liver. So how often does this happen? And this really is an unsatisfying answer, but it depends on many factors, particularly the characteristics of the transplant, how the transplant was done, the donor and the recipient. But studies tell us that anywhere between 10 to 50% of patients will develop acute graft versus host disease. And the major risk factor for this disease is really the degree of difference in the HLA proteins between the recipient and the donor. So you might remember that when we're doing a stem cell transplant, an allogeneic one at least, the main thing we're trying to match between the donor and the recipient are some important proteins that live on our cells called HLA proteins. And the more difference there is between the donor and the recipient, the higher the chance that you're going to see that butting of heads that we mentioned at the start. And that tends to be by far and away the biggest risk factor for acute graft versus host disease. The good news is we can do our best to prevent acute graft versus host disease. So your transplant team will have a plan. This starts with, if we have the option, selecting the best donor available. And this varies. Unfortunately, not everybody has a great donor search and multiple options, but if there is the luxury of selecting from among multiple donors, we're often trying to select the donor that will lead to the best outcome, and that includes the lowest risk of graft versus host disease. We also use medications to reduce the risk, and these are the most important part of preventing graft versus host disease. Any number of these medications listed on the slide here might be used, and often a combination of them is used. So if you do develop acute graft versus host disease, how is it treated? For early acute graft versus host disease, for example, a skin rash that's localized to just a particular area of the body, steroid creams and lotions might work to reduce that inflammation. When the graft versus host disease is involving a more extensive area of the body, like a rash that's involving most of the skin, or when the liver or GI tract are involved, we tend to need corticosteroid pills, drugs like prednisone, to help really settle down that new immune system. So what's the prognosis? Again, there's no clear answers here. Studies tell us the good news is less patients are developing severe acute graft versus host disease now as compared to prior decades. And that might be because there's better technology to kind of characterize those HLA proteins of the donor and the recipient that I was mentioning earlier. And so that allows us to pick a closer matched donor. We also now have better drugs to prevent and treat acute graft versus host disease and to support patients as they're going through the treatment of acute graft versus host disease, particularly trying to prevent infections. As you can imagine, when we're using drugs to suppress that new immune system to treat the graft versus host disease, there is a pretty significant risk of infections, and our toolbox in terms of preventing and treating infections has certainly expanded over the last decades, and this has led to better outcomes. Many patients will respond to initial treatment with those corticosteroid medications that I was mentioning. If they do not, we now have more options for treatment than we did in the past. So what can you do as a patient or a caregiver? So the first thing you can do is to be informed. Ask your transplant team about what medications will be used to prevent acute graft versus host disease. Then it's very important to take your medications as prescribed after the transplant. These drugs are still working even after the transplant is said and done and you're out of the hospital. These drugs are still very important in terms of preventing acute graft versus host disease. And so taking them as prescribed is very important. And then, of course, knowing the signs or symptoms of acute graft versus host disease, as we've mentioned on the previous slides, will help you to get in touch with your transplant team right away. These are not symptoms that should be sat on for days at a time. You should be in touch with your team if you are developing any of those symptoms.